Thanks for attending the Dundee FRCS course. This is a continuation of the slides for top tips for otology. Please note, this is only purely for educational purposes. Please don't misuse it, and please don't post on the social media, etc. In the continuation of the first talk, when it comes to the assessment, they may ask about speech banana. Don't get baffled. They may draw you, or they may ask you to draw you. Speech banana is created by plotting the sounds of human speech in an audiogram. It kind of assumes a shape of a banana. And please note, where is the consonant, where are the vowels? Some examiners may ask you. And then if there is a hearing loss within the speech banana, then it can affect the child's ability to learn a language, acquire a language skill, which can have significant impact for the child's development. And there are some questions to make come about sudden sensorineural hearing loss. By definition, whenever there is more than three consecutive frequencies are affected, there is a more than 30 decibel difference, and within more than 3 days. I always used to assume like rule of threes, 30 decibels within 3 days, then it's called sensorineural hearing loss. Causes could be varied, could be starting from idiopathic, infective, which can be bacterial, viral, spirochetal, labyrinthitis, meningitis. Other things like trauma, vestibular schwannoma can present like that. Autoimmune conditions, usually bilateral, and neurological conditions like multiple sclerosis can present like, as well as other conditions like which can produce sudden sensorineural hearing loss include Meniere's disease, diabetes, very common, sarcoidosis, as well as non-organic hearing loss. Coming to examination of sudden sensorineural hearing loss, please rule out for sudden hearing loss, could be conductive or sensorineural. Please always say to the examiner that you rule out things like complete wax occlusion, medullary fluid, and you'll do the tuning fork test for the examination wise. Also include audiogram and stapedial reflex, what is a pathway, how to do it. Towards investigation of the etiology, you can include a series of tests starting from basic thing like urine analysis for diabetes and other basic hematological tests like full blood count, ESR for autoimmune conditions, lipids, blood sugar estimation, immunological profile. Also for spirochetal like syphilis, as well as for Lyme's disease, you include appropriate tests for that. Autoblast test for 68 kD inner ear protein can be done, but not everybody uses it, not available widely. And for imaging as well, for example, for sarcoid, can have a chest X-ray, and then MRI scan for acoustic neuroma, or if there is central cause, can be done. And coming to the predictors, which patients get worse prognosis with sensorineural hearing loss. If the patient is elderly, obviously going to have a worse prognosis, and the time of treatment line from the treatment line start from the time of diagnosis has got an impact. There is a severity of hearing loss worse. They have associated other inner symptoms also prognosis worse. They have a severe pain. In some studies showed the prognosis worse as well. Roughly 2/3 will recover. If they have more than 90 decibels affected, only 20% will recover. Whereas it is better if the hearing loss is less than 70 decibels. Means the 80-85% can recover easily. And also acoustic neuroma, 3 to 5% of sudden sensorineural hearing loss can have acoustic neuroma. And I've seen 1 or 2 cases when working in the skull-base unit, and literature quotes up to 15% of acoustic neuroma sometimes can present with sudden onset sensorineural hearing loss. Whenever there's a 8 kilohertz affected, has got poor prognosis. Also know about topical ear preparations, treatment for otitis externa, what to use, commonly use it. Please know by heart. Examiner may ask, okay, what are the things available in it? What are the constituents? And then please be prepared to answer about the contents and percentages. And also treatment for common conditions. For example, otomycosis, how long you are going to use it. So once the spores once the fungal infection has been cleared, spores will come back. So you need to use that to clean it, to treat it as well. And dizziness is a very common topic because we encounter in the clinical situation every day. We encounter it in any clinic. And please stick to what you do in the clinic. Also have a coherent examination flow and also able to answer any questions what they ask. 90% of the time in dizziness, mainly thing is history and some bits are important for the examination. And as I mentioned, have a practice how you are going to explain all this, including the examination, how you are going to do the Dix-Alpec test, what is Romberg-Stein, how you are going to elicit it. This can be asked, so don't get baffled about it. Also know about other causes of dizziness like barotrauma, perilymph leak, as well as CSF leak. There will be another question about autoacoustic emissions. Same way like ABR testing. They may give you a situation like you are a consultant. They ask you to kind of arrange a screening program. So what are the criteria for it? So there's a few things which you can kind of quote it. The condition for which the screening has to happen should be very prevalent. It should be a treatment available and effective testing and intervention should be available. And it should not be very overburden to the health system. It should be cost effective as well. You should be able to monitor it very easily. And you can always say about the examples of screening test. All this criteria is called Wilson's criteria. As I mentioned before, there may be some other things, especially in terms of brain abscess or dizziness. They may ask you about what are the signs for meningitis. Could you explain it? Please know about Kernick's sign, Brudensky's sign, what is Toby Ayer test or Quick-and-Stats test. So few important things, please note it and please be able to tell it to the examiner. Kernick's sign, when the hip is in flexion, patient can experience pain on leg extension, and Brudensky's sign is flexion of the neck causes reflective flexion of the leg. Whenever there is a thrombosis of the internal jugular vein, there is no increase in the CSF pressure due to the thrombosis. And acute otitis media cannot be stressed enough. It's a situation which can come in multiple ways. Emergency scenario definitely will come kind of different stations as well. Also, please note the patient has got fever after EVOM. You have been treated and treated. Please have wider, broader perspective of how patient can have fever. That includes metastatic abscess elsewhere. Please be aware about the situation, though it's not common. Also, how would you treat it? A little note about consent. They may ask you to do some consenting for master surgery, and then can you consent me? The examiner may ask. So as you will be doing it day in and day out, it's a little summary of how a consent can be done. Like include no treatment option, but medical, surgical, and other treatment options as well. You have to give the wide variety. And of course, you would prefer only the treatment, appropriate treatment, which is evidence-based to the patient. So indication, description of the procedure, complication of the procedure, what's the follow-up period, patient will require time off work, what are the things they can do or they cannot do, any social adjustments needed. Those things you need to include. That includes the post-operative course and care and also follow-up. Please be aware about the shock and definition of the shock. What I used to say, circulatory mismatch. Also the stages of shock. I used to keep it as a tennis rule. Like stage 1 is up to 15% loss. Stage 2 is 30% loss of blood. Stage 3 shock is 40% loss of blood. And stage 4 is more than 40% loss of blood. Please know about the NICE guidelines, side guidelines about common ENT conditions and common classifications. Please read about necrotizing otitis externa and ins and out. There is a good topic discussion in the ENT masterclass, and in one of the topics it describes something about clinical pathological classification. Sometimes the discussion may start with something simple like air discharge, and then they start with otitis externa and then rapidly progress in different areas. And don't be baffled if they put up a tympanogram and then ask you what it is. Please be aware what kind of frequency they use in children, adults, and infants. Also the different curves of the tympanograms. Be confident about it. These are the questions which you can easily score the points, like type A, type B, type C. This is a short discussion only about top tips about otology. There will be multiple talks following the presentation by the consultants as well. And all the best for the examination. Thank you.